All right, so now we're going to move on to our first panel discussion, focusing on implementation science and operations alignment. And we thought this would be an important follow-up of Dr. Tobin's talk in order to bring together our colleagues who are in operations and in education to provide us some more insight into how this work can be done. Our first panel member is Dr. Christopher Cooper. After completing his internal medicine residency and cardiology fellowship at the Brigham Women's Hospital and Harvard Medical School, including an intensive care course in clinical effectiveness at the Harvard School of Public Health, Dr. Cooper joined the cardiovascular medicine division at the University of Toledo Medical Center. Dr. Cooper served as professor and chief of the cardiovascular medicine division at UTMC from 2002 to 2012, when he was named chairman of the Department of Medicine. And in August 2014, Dr. Cooper was appointed to the position of Executive Vice President for Clinical Affairs and Dean of the College of Medicine and Life Sciences at the University of Toledo. He founded the Cardiovascular Medicine Research Program and the Heart and Vascular Center at the institution. And then in April in 2019, Dr. Cooper was appointed to the rank of Distinguished University Professor. And in 2019, Dr. Cooper was appointed to take on additional responsibilities as Vice Provost for Educational Health Affairs at the University of Toledo. He mentors undergraduate, graduate, and medical students, as well as residents and fellows in research. Our second presenter is Dr. David Aron. Dr. Aron is Emeritus Professor of Medicine at Case Western Reserve University School of Medicine. He's retired clinical endocrinologist with experience in research, including participating in developing the Consolidated Framework for Implementation Research, one of the original theories in implementation science. And he also functioned in education. He's author of the book Complex Systems in Medicine, A Hedgehog's Tale of Complexity in Clinical Practice, Research, Education, and Management. He's been grappling, or maybe wrestling, with complex systems his entire professional career, and I must attest that Mr. Hebert and I are both his mentees from the VA Quality Scholars Program in here in Cleveland. And then our last panelist is Dr. Bruce. Dr. Douglas Bruce. He is the Professor of Medicine at Case Western Reserve University School of Medicine and Senior Vice President, Chief Clinical Integration Officer at MetroHealth System. Dr. Bruce is responsible for coordinating and integrating clinical and medical operations across the MetroHealth system to increase quality of care, advance health equity, enhance patient safety and engagement, and optimize the overall effectiveness of MetroHealth's clinical enterprise. Dr. Bruce has worked to develop and implement research and public health interventions both locally and internationally to improve HIV, HCV, and tuberculosis care. Dr. Bruce supported the launch of the first public methadone program in sub-Saharan Africa and provided technical assistance to the CDC, the United Nations, the USAID, and non-governmental organizations to address HIV and substance use epidemics globally. So thank you all for being here today. We are honored to have you, and we would like to have you discuss your role in operations and alignment with implementation science. And so we're going to start with your stories, explaining your roles and perspectives of implementation science. So Dr. Bruce, would you start for us?
Good morning, and thank you all for the opportunity to be on this distinguished panel and talk about some of the challenges of implementing any operational improvements within hospital settings. So I guess I'm newer to the Cleveland area. I've been here almost 2 years. I came by way of Boston. And when I think about operational challenges and bringing implementation science within hospital operations, I think the first key piece is that hospital systems, by their very nature, are dysfunctional. They are kind of a chaotic mix of different actors with different goals trying to achieve different ends. And as such, they compete for resources, they compete for time, they compete for money, they compete for energy. And that is the kind of chaotic soup that implementation science needs to come in, watch, account for, track, and then try to help make sense of as we try to move forward operational change. My interest in this space really began because I started out as a researcher and then wound up in operations. And my concern was when as a researcher, I would look at what operations did. They were really functioning in an anecdotal environment, trying to kind of, the old kind of artist who puts a thumb up and decides, well, this looks pretty good. Why don't we try this? And they weren't applying any form of science, whether it be quantitative or qualitative, to try and think about, well, what have others done? What's the best outcome that we could achieve? And how are we going to take that, adapt it to the context of our system, and try to achieve that together? So that's kind of what's landed me where I am now in my excitement in participating in this panel. And I'm sure there's a lot more that others can say. So I'll hand it off to Dr. Cooper or Dr. Aron.
You could share your story.
Oh, there's Dr. Cooper.
Oh, Dr. Cooper? Yes, we have you on camera. Great. Thank you.
Okay. Good morning. I'm going to talk about two things in implementation science, and maybe this is not really the tradition of implementation science, but like trying to start things and then trying to stop things. So one of the things I did early on in my career is I'm an interventional cardiologist. Is 94 started doing transradial coronary interventions pretty early on in that, and what we noticed is that people who had a transradial procedure, the nurses liked caring for them because it was easy, and the patients liked it because, especially those who had a prior transfemoral, they could get up and walk around, didn't have to lay flat with the sandbag on their groin, which we did 30 years ago. And so from those clinical observations, we designed one of the early randomized trials where we measured quality of life and cost effectiveness. We're able to demonstrate from that randomized study dominance, right, where it was cheaper to take care of patients, less interventions to provide care for them, less bleeding complications. We also showed that their quality of life was better. And so it was great, right? Like, I mean, we showed this nice outcome, but that doesn't actually implement anything, right? And so in order to kind of get things moving, we did local training sessions for physicians here in Toledo. People would come in, and then that worked pretty well. And we then started doing training courses around the country, Boston, New York, California, training physicians how to do transradial procedures. And what's really nice is that 30 years later, now in the current guidelines for coronary revascularization, it's listed as a 1A strategy. Transradial is preferred over transfemoral. And so I guess the thing I would say is first start with solid research and try to collect the data on your clinical observations. And then you have to have a strategy about, like, if you think it's helpful, how do you train people locally? And then can you generalize that to a broader community? And then I'll talk about the opposite. So slightly after that, I was interested in this condition called renal artery stenosis. And we thought, like, hey, we could open up these kidney arteries, maybe patients would do better because there's a lot of coexisting kidney disease and heart disease and heart failure. Did a fair amount of research, showed that quality of life was better after a stent revascularization procedure. So over time, we were able to get a group of people together and design a large randomized trial, NIH funded. We brought in industry partners to pay for medicines and stents and this and that. Published that in 2014 in the New England Journal. And it was the opposite, right? It showed like medical therapy was equivalent to medical therapy plus stents. Amongst my interventional colleagues, that was a little less popular than, hey, this radial thing is better. And so, the implementation on that was, really just getting the word out. And it was, presenting the negative findings at national meetings and in conferences and participating in debates where my colleagues said, like, oh, this is terrible. You showed this thing that we like doing doesn't really help. But, writing book chapters, writing review articles, and really participating in the dissemination of the science. And that's now, medical therapy is now the level 1A guidance in the hypertension guidelines for people with renal artery stenosis. And so, I guess maybe I'm more of a traditional clinician scientist, but I think if you just do the science and you don't have some kind of strategy to get the word out and let people know about the findings, you have the potential for having findings that just don't make an impact. So those are my comments.
And then Dr. Aron?
Well, I'm a real skeptic when it comes to implementation science. I'm not a skeptic when it comes to implementation. I'm not a skeptic when it comes to science. But implementation science, not so much. And I think that there have been a number of critiques of implementation science in the past few years. And what I think IS has added is more rigor to the evaluation of what we implement than things that are, really generalizable that I can take from A and move to B without adaptation. Now, it's interesting. There was a review article of what were the evidence-based strategies to implement, for which there was really good evidence, RCTs, audit and feedback, opinion leaders, education and training, and computerized reminders. The fact of the matter is that there is biblical evidence for the first three. And just as an example, audit of feedback, just check out chapter 5 of the book of Daniel, which was written about 2,400 years ago. I got into implementation sort of by the back door. I was a bench scientist and I became associate chief of medicine, and I was put in charge of ambulatory care and quality. The latter about which I knew pretty much nothing. We embarked on a major implementation of a total reorganization of our general medical clinics. And I sort of learned that I had been speaking prose all my life, and I didn't realize it. That was published in 95. I think what IS really has to offer, and what researchers have to offer, is a way of thinking about what you're doing that you can learn and apply where you are, and maybe it will resonate with somebody else. But don't be fooled into thinking we've got these, universally applicable strategies. And by the way, I would disagree with Dr. Bruce. Hospitals are not chaotic. They are complex systems, and there's a difference. You can work with complex systems.
Good.
Thank you so much, everybody. I love this panel because you are all so unique in how you're approaching implementation or thinking about implementation. I actually love the chaotic soup. I was thinking I should use that phrase sometime, Dr. Bruce. So I think that that is something that we as in the world of implementation science are just always understanding that you need to be able to deal with complexity or else you shouldn't be doing this work. I think that one thing I really wanted to point out from Dr. Cooper's comments is that a lot of people are kind of implementing and not thinking of themselves as implementation scientists. And so, I mean, the 2 points that you had made, one about implementing the radial artery procedure and then de-implementing the renal artery, the treatment for renal artery stenosis. I think that a lot of us are maybe thinking about this as, okay, this is something we need to do to get the word out and to really bring our findings to practice or to let people know this doesn't work. But we're not using the terms that implementation science has kind of created for this process and studying that process of bringing research into practice or taking knowledge and taking certain practices out of what is going on. So what would be the advice, I would say, I'm going to have everyone kind of weigh in on this, for people who are maybe doing this work, aren't not feeling that they're speaking the language of implementation science, but would like to formally study implementation in the work that they're already doing. Because I think that is what we're really trying to build in our CTSC, is just kind of this way of thinking, Dr. Aron, that you just pointed out. How do we bring that way of thinking into clinical researchers into practitioners' worldview, that maybe they just aren't thinking of themselves as implementation scientists, but actually doing the work. How would you suggest promoting more of implementation science evaluation more generally in the work that people are just doing either clinically or with research? So I will, Dave, you're on camera, so I'm going to ask you first.
Well, we could use the evidence-based strategies of audit and feedback and education and training and opinion leaders. And I don't think computerized reminders are going to do a heck of a lot in this particular circumstance. I think the best way to do it is demonstrate that it's fun. Mm-hmm. It's really fun to do this stuff. Then you learn the language, so you get your secret decoder ring that makes you a genuine, implementation scientist. Every discipline creates a language that nobody else can understand. I mean, that's the beauty of disciplines. So you gotta get that secret decoder ring. But if there's something fun about doing it, it's really nice. And I don't mean fun, haha. I mean fun, you accomplish something. Right. And it makes you feel good about being the professional that you are.
Thank you.
And that's why I trained people like you and like Mary. And I emphasized fun.
Yes, the joy of the fun. You're right.
Thank you so much. And I think we need to use that word more when we're doing these sessions. Thank you.
Seems like a key to culture change.
Yes. Mm-hmm. Mm-hmm. Chris, do you have a comment on that?
Again, I don't know that I'm necessarily the expert on implementation science per se. I will relay, though, an experience yesterday. So we spent all day with our medical students, second-year medical students, on a simulation exercise. And what's interesting, I think this is generalizable to people, is that we learn snippets. Like, the kids learned how to read an EKG in their Thread 3 curriculum, and they learned how the coronary heart disease develops, et cetera. But when you put them in a clinical scenario and ask them to actually implement those things, oftentimes it's disjointed and disconnected. And, I think actual practice environments where people can figure out how they're going to utilize the things that they've learned to take care of people is something that we underestimate. And so, as an example, the scenario yesterday is a person presents with a heart attack, and then we put them into V-fib, like in a mannequin, and then they have to do the resuscitation. And almost invariably, when they get done with the resuscitation, they stop and they forget that the person had a heart attack and they need to go on to take care of the heart attack, right? And in a similar way, like in the transradial thing where we train people, like putting them in an environment where they can actually see how it's done and see how it's implemented into clinical practice and can become part of their practice, I think is really important. Because other times, a lot of these things we teach, we're like, oh, it's just really straightforward, et cetera. But people don't know how to actually do it practically and how it fits into the framework of the delivery of care. And so, thinking about like, how are we going to integrate these things, I think is really important. And then the final piece I'll make, which may raise some eyebrows, but that is partnerships with industry. Like most of the things, or not everything, but a lot of things we're implementing are drugs or devices or treatments. And our industry partners have a great interest in that, right? Because they sell the drugs, they sell the devices, and figuring out a way to work collaboratively with industry who provide the tools for success, I think can be really helpful in implementation. So those are my two comments.
Thank you. Thank you so much. And actually, that kind of, Doug, if you could comment, that's a great segue into this idea of integration and really showing the value of being able to have this implementation knowledge of how things are implemented. And in your role, Doug, as an operational leader, when you think about this kind of chaotic soup, do you have any suggestions for how operational leaders could partner with implementation scientists or researchers, and what would be a model for doing that that you think could be successful in the operational world?
It's a complex question. So I guess I'd first add to what David and Chris were saying by agreeing that those things which are fun and bring joy, people invest more time and energy in. And healthcare operations in health and complex chaotic systems is taxing and challenging. And where you find the joy, you can build sustainability. And I agree with Chris that you really have to, you can't assume that people have the skill set to do some of these things, right? We train, college students go through med school to become physicians. There's a lot of training. And so sometimes we assume that people have a base knowledge in implementation science that they don't have. So I guess the thing that I would add is that there's also an identity crisis among clinicians. So I've been in large academic, very competitive environments, safety net hospitals, community health centers, international healthcare settings. And in some sense, in all of those settings, people were providing HIV care and almost using the same medication. But they had very different views about academics and their role in system change. Right? So when I was at Yale, you dangled data, you got ran over, and people took the data and published, right? So it was very competitive. Everyone thought, I'm not just a clinician, I'm an academic. Part of my job is system change. In the safety net world, in the community health center world, it wasn't that. It was, I'm a clinician, other people do academics. And there was a disconnect between the fact that actually what you're doing, contextualizing the care of high blood pressure or the treatment of Chagas disease or whatever to a particular context, that's an implementation science. Like you're doing it, you just don't think that what you're doing is academic or academically important. And so you don't think, well, I should talk to somebody about this. I'm just in the trenches and I'm trying to solve a problem for the patients that present to me today. And so in some sense, I feel like, when you leave medical school, people talk about, I'm going to go do clinical work. I'm going to go do academic research. I'm going to go do education. But we're kind of, I think, in some sense, it's good to have divides and specialization. But in some sense, it's a big misstep. We need all of the clinicians to remember that research, ongoing research, is part of being a clinician. Because, I take care of people who use drugs, who have mental illness and infectious diseases. So traditionally, all of my patients were excluded from every study on HIV care. So, they would have all been excluded, right? You don't sign up paranoid schizophrenics with HIV and ongoing heroin use to your study. So that means that I'm always extrapolating data to the context of the patient, right? That's implementation science. What's the evidence, the data? How do I apply it in the context of my patients? How do I make a difference? Those are academic questions. So I think that in addition to the fun, in addition to the education, we need to help people have an identity that as a clinician in the trenches, you are an implementation scientist, you are doing change, you need to be partnering with people because you need to grow that.
Great. Thank you, Dr. Bruce. I love your conversation and your dialogue a bit about this topic, that there's this need for alignment of academia and practice and operations, and that oftentimes we don't think of that. But that could be something that we could educate people on. So I'd like to just ask a question a little bit about education. And just to give you a little bit of background, in my career, I focused on quality improvement in operations, and then I had another life of a scientist where I was NIH funded, but I had to live my lives a little bit separately. But back in the day, quality improvement was really where we did most of our education and training with both practitioners and with students. So the question to all of you is, how should we change our education now to align our students and our practitioners to see this, I think, synergy between the two in a little bit of a better way? And I think, as you mentioned, Dr. Bruce, to get them to be systems thinkers, where they're not just going in to deliver clinical care, but also to think of systems. So I don't know, since Dr. Bruce, they're still on camera, maybe you could start this round of questions.
Like, I'll just kick it off and then pass it off to David and Chris. I think, so my training was a little unique in that after residency, I went to graduate school and was trained as a researcher. And so I came to community health settings or international settings or even hospital operations with a research mindset. And so when I'm faced with an operational problem, I think about it like a research question. And so I want to kind of follow a scientific process of, well, let's get some data. Let's talk to stakeholders. Let's get quantitative and qualitative data. Let's map out a plan. Let's pilot it. Let's get some data. Let's course correct, improve, kind of that step wedge iterative process. Let's apply science to hospital operations. So what to me seems very logical and natural is really because I had this biased upbringing in a sense of I was brainwashed that everything is a research question and everything is solved by a research process. And when I interact with a lot of hospital operations people, they come at these problems from a completely different mindset, right? An MBA is coming at this from a finance business. How do I get from A to B as quickly as possible with the lowest spent dollars and the greatest return on my investment, which is a different pathway than the pathway I'm coming at it. HR is coming at it from a different view. Legal's coming from a different view. Same problem, different views, different stakeholders. And often because hospitals are running on tight margins and moving quickly, people are pushing for the fastest pathway forward. And so physician leaders that come in who have some sense of all of those other pathways are important, but we've got to do this right. And we're going to need to apply an implementation science framework, a really thoughtful iterative process can really help build sustainable solutions. And I think that's one of the reasons I know David and I disagree on my term chaotic, but the reason that I had used the chaotic term was simply because I see a lot of things start, fizzle, trying to rebuild on this, fizzle. And it's because we didn't take enough time to do problem formation. What are we really trying to do? What's the real data that's going to inform this? Who are the real stakeholders participating in this? And what are we piloting to try and make sustainable change? Too often change is, I need to fix today's schedule in the next 15 minutes, and I'm going to Band-Aid a bunch of stuff, and I'll get back to this some other day. Some other day just doesn't happen. And with that, I'm handing it off to David.
Great. That's good. Dr. Aron?
Well, I will take off my Conan the Grammarian hat. And just suggest one way. So I have a very similar background to Doug. Although I wasn't in graduate school, I came to Cleveland to learn bench research, which I did for 15 years before other stuff. What I find helpful is that for medical students, we train medical students to try to think like doctors, focused on patients. But patients in a complex system, dare I say, they're nested. Patients are nested within clinician-patient relationships, which are nested within, clinic operations, which are nested in hospitals and so on. I think if we get our medical students to think about the systems as their patients and think about the systems in the same way we think about patients, we have a waiting time problem, okay? There's your diagnosis. Well, what can you do about it? Okay, but thinking in those, it's an approach towards systems thinking, I guess is what I'm saying. And yes, it is. There is a lot of chaos.
Okay, and Dr. Cooper, from your perspective in academia about educating our next generation.
So look, we've talked a couple of times about systems, improving systems, and I think that really is a critical issue. But I'm going to step back for a second. And I think the role of a physician right now and their ability to modify the system is almost at a crisis level, right? Because most of our institutions have implemented these complicated electronic medical records. We're rating physicians on a number of measures, how many patients they see and how fast they see patients and do they meet these metrics and blah, blah, blah. And there's all this stuff like piling on, right, to our students and our residents and our fellows, and they're making career decisions based on these pressures that are piling on. And I don't think most of our doctors really are thinking about the system per se. They're thinking about like, how do I get through today? And I really don't want to spend all evening working on my electronic medical records because I like to talk to my wife or maybe spend a few minutes with my children or my significant other. And so honestly, I don't think we're quite there with practicing doctors. The one response I would give is that anything that we can do in the systems that fit with Occam's razor, his thing is, the answer with the least assumptions is typically the right answer. The simple answer is the right answer, the way it's been phrased. Ways that we can simplify systems to allow people to do their job, I think meets Dr. Aron's goal of finding joy in work. Because again, practicing physicians, most of them like talking to their patients. They like doing the physical exam. They like coming up with diagnoses or doing things. What they don't like is all the other stuff that we're being asked to do right now in the provision of care, pre-certification. Like, oh, okay, right. Like I got to now prove to somebody outside of my system that this care is warranted. And all of the different things we're expected to check and do and box and whatever to make sure the EMR is complete. It's a distraction to what doctors are trained to do and really have goals to do. And so for me, one of the important things is what do we do in our systems to lessen the burden and simplify care to make sure people get the right care.
Thank you. Thank you so much for all of your responses. And just to respond to the last one, as a practicing clinician, Dr. Cooper, I do understand everything that you just mentioned. And I think that the goal, as Dr. Tobin mentioned in his keynote, just about making sure that where you're implementing your intervention and what you're trying to study, that you're on the same page with the same goals as the people who are going to be receiving the intervention. And the importance of that can't be overemphasized. And I think that, just this goal of implementation science as a tool to improve the quality of care that we deliver to patients, and always keeping that in mind as the end goal. And how can we do this effectively by making it easier for the providers to, in a health system setting, or if we're talking about a community setting, making it easier for community members to kind of have the choice for uptake be the easier choice. And so I think that I do very much respect what you've said, and I think just aligning with what Dave and Chris said, or Dave and Doug said as well. That everybody just kind of has their goal in mind, and as evaluators, we have to understand that and not come in and create burdens. I'm looking at a question that we received from an audience member just about the jargon of implementation science, which I do try to avoid, and I think hopefully we're promoting within our CTSC this awareness that you don't have to have that decoder, and that we can actually all be on the same page with the same goals for improving care that we're providing, either to our patients and health systems or our communities. The question is, how do we balance this jargon with need for inclusivity for others to participate in this work? And I think I kind of had asked Doug maybe prematurely about this. What are some mechanisms we can use to improve this alignment of rigorous implementation evaluation with operational needs, with educational needs, with basic clinical needs that our patients have, and while we're still trying to perfect these processes and study these processes. So any thoughts from the panel on how you view implementation science as an exclusive field somehow that has jargon. We'd love to hear just what you think about that. Dave, thoughts about that?
Well, there are really two fundamental goals of having jargon. The first is exclusivity. That's a goal. All right. The second is communication, and it facilitates communication within the cognoscenti. However, if you're going to implement things, the types of cognoscenties vary tremendously. And you've got to be able to communicate across multiple languages. So, for example, I proposed about 25 years ago that the way to train implementation science researchers was to take them and embed them in projects that were implementing something. Now, they didn't want to go anywhere near this. I mean, God forbid. But it's about facilitating communication. And that's the goal. If you can't communicate, what good is it? Mm-hmm. And if you can't succeed without including people who don't know your language, you better take a little Berlitz's handbook, right? So you'll learn a few key phrases.
So actually, I want to thank you, David. I want to pose this question back to Doug about, you're coming from a research background and now being in this operational role primarily. I'm sure you still interact with researchers, and I wonder if you have perspective on that in terms of how you feel that you need to be supporting the operational needs while communicating with evaluators.
Yeah, so it's a great question. So it's really about an ongoing dialogue. So there are the researchers who have like this great idea that they want to study it somewhere, and they kind of shop around for it. And sometimes it lands because it's a great idea that has practical applicability. And sometimes it's really interesting to them, but has no interest to the community, right? And so that's a little awkward and challenging. And so you kind of have to speak in two languages to try to get my Berlitz book out, as David mentioned, and kind of help the researchers understand. I understand that's an interesting research question. You will get no participation from the clinicians because they don't care. Like you're going to have to either you're going to have to get some outcome measures that they care about, or you're going to have to rethink what you're doing. Because just because you think it's a good question doesn't mean anybody's willing to follow you. And so that you can understand is somewhat of a challenging conversation. On the clinical side, part of it is also saying, what are the things that you're facing, right? Instead of just telling me things are broken, what exactly is broken? So kind of pushing them on problem formation. Because then you can start taking things over to the researchers and saying, here's a laundry list of challenges that people are facing. And, like you're interested in cardiovascular outcomes, researcher. And look, we're not getting LDLs on everybody. We're not getting, I have 47,000 diabetics. Every one of them needs their retinas examined annually, right? I get a fraction of them. If anybody on this call is interested in solving that problem, call me later. So there are lots of really interesting problems that can go back and forth, but a lot of it is really trying to bridge the conversation. Too often they're talking at each other and everyone's frustrated, but if you can get them to the table and find common ground, then people are willing to move forward.
Yeah, thank you for that. It's very interesting. Implementation science has really been around maybe 20 years or maybe a little longer, but I know the conference that they have for implementation and dissemination, it's in their 17th session this year. And I know when Aron went back at the very first one, he came back to the VA and said, there were 60 people there. And now there's over 5,000. But it seems like we're at this intersection now where we really need to get this synergy between operations and the communities and our scientists better aligned. So I think the last question to all three of you is what strategies or methods or approaches can we take to get at a better maybe awareness of the importance of working together to this common goal? And so we could start maybe with Dr. Cooper.
Yeah, I mean, I think implementation science is the basis of good medical care, right? Like you can have great ideas, but if you can't implement it, it doesn't work. There's this old idea that the basis of implementation science is that new ideas come up and then old people don't adopt them. They have to die off for the next generation to actually adopt the new idea. I think implementation science is just trying to get the wheel to spin faster, right?
Mm-hmm. Okay, great. And Dr. Aron?
Well, I think there's one thing that like a moth goes to flame, clinicians and researchers go to money. And if you think about who are the people who've been really good at getting things implemented, it's the drug companies. They've been really good. How do they do it? They spend a lot of money on it. And one of the fundamental problems of implementation science, I think, is we're trying to find how to accomplish what the drug companies do for very little money. And I don't think that's realistic. I think the biggest problem money-wise is in the funders, is in research funding. And they're looking for things that are, from my perspective, pretty much irrelevant. And until that changes, I don't see a whole lot of change. But then again, I'm one of the old folks, and so I'm going to die off.
All right. Well, they do say it takes 17 years to get evidence into practice, but hopefully it won't take us another 17 years to get this one right. But how about you, Dr. Bruce?
So I guess two things to build off of David's comment. People follow the path of least resistance, and so when you want to, when you go to a clinical system and you ask people to do more, they're going to be immediate resistance. And I think, as David and Chris were mentioning, you have to have some kind of lever to overcome that inertia that wants to keep systems following the path of least resistance. And money is one of those. Some systems try promotion, other things, accolades to do it. But when you talk about how do we bring operations and implementation science closer together, I think something that's really important is going to be longitudinal relationships. Mm-hmm. So often what I see is a group, the life cycle in a research institution is you're constantly thinking about things, you're writing grants, something gets funded, and then you're thinking about, okay, who can I partner with on the execution of this? And so, but if you're on the clinical or the hospital side, what you see is this group kind of comes and goes, and they only talk to me when they need something. And I'm not really sure what I'm benefiting from this. The paper gets published and it says, Harvard Med School or whatever, and it doesn't even include my institution. I'm in the methods of a safety net hospital in Boston, right? You think, well, what? I'm not getting reputational benefit. My faculty are working harder. What's in it for us? And one of the things I tried for years in New Haven to get the kind of implementation science group there to start thinking about was you need to have a long-term relationship with stakeholders in the community and the hospital system. Because asthma, for example, is a problem whether or not you have grant funding. But if the community and the hospital operations people see, well, you're my content expert. You're the people that help me. You're the person that I can call when I need some advice. Then when you have a grant, I'm very interested in listening to you because we're partners, right? You're not just coming to me and I'm giving you what you need. There are things that you have that I need and you're participating with me. Now it's about a long-term relationship and that's sustainable. And so I continue to encourage people to start thinking about what are those key kind of large-scale population health-related problems that we have that we're wanting to tackle in implementation science and start developing those relationships with hospital systems. And then you'll find willing partners over time, as you weren't coming and going, you were in it for the long haul. And that's what hospital systems need to see.
Yeah, that's great. Wow. That's a great place to end for this session. Thank you all, Dr. Bruce, Dr. Aron, and Dr. Cooper. This has been a really interesting and thought-provoking session on where do we go from here to align operations with implementation science. And I think key messages are that longitudinal relationship is key, and then to really make this fun and change the culture a bit. And then have our operations partners help the system to support the research and the clinicians' work. So thank you all today. We very much. We will now take a 5-minute break, and so we will reconvene at 9:50. Thank you.